So shall we start?
Sure, absolutely. I'll just
Okay,
share my PPT.
sure.
Let's
Good evening,
see
all the
whether it is
aspirants
visible or
of.
not. This is visible, right?
Yes, it's perfect.
Okay, and let me put it in slideshow. Okay. Now, let me just see if the slides are moving forward or not. It is, right?
Yes, so the slides are moving.
Okay, fine. So, as it is going to be a rapid fire sort of a session, and we're going to cover two topics here, infectious disease as well as AKI. I'll be running slightly fast throughout this thing, and maybe if there's something that we can address specifically, then we can talk about it at the end of the session. So this is for the crash course, and so what do you have here? A 65-year-old woman, history of type 2 diabetes mellitus, presents to ICU with fever, hypertension, and confusion. She was recently discharged from the hospital after surgery for diabetic foot infection. She's febrile. Her blood pressure is 85 by 50 mm of mercury, and she has tachycardia. Now, blood cultures are positive for gram-negative bacilli. So, what is the most appropriate initial antibiotic therapy? You can, put your answers in the chat.
Meropenem.
Please put it in the chat. Then it becomes difficult. Well, I believe somebody did get it right. So the answer is indeed meropenem because it is basically a gram-negative sepsis. And it may possibly involve MDR organisms because of a recent hospitalization and surgery. It is basically broad spectrum carbapenem, effective against a wide range of effective against a wide range of gram negatives, including ESBL producers, and that is an appropriate choice for empiric therapy in this setting. Second one is a 45-year-old male who would present to the emergency department with severe dyspnea, high fever, and a productive cough. Now, he has got a history of smoking and recent travel to an area with a known Legionnaires' disease outbreak. A chest X-ray will show bilateral patchy infiltrates. Now, which diagnostic test is most specific for confirming the diagnosis of Legionnaire's disease? Okay. What about the answers? Okay, so somebody has got it correct. Okay. So the correct answer for this would be the urinary antigen test. It is highly specific. It provides very rapid results, which makes it the most useful diagnostic test for Legionnaire's disease, especially if you're having an outbreak. We go on to the third one. 50-year-old woman admitted to ICU with a severe headache, photophobia, and neck stiffness. She's febrile. Her blood pressure is 110 by 70. You do a lumbar puncture, which reveals a cloudy CSF with a high opening pressure, elevated white cell count with a neutrophilic predominance, low glucose, and high protein levels. So, what do you think is the most likely causative organism? Seems to be easy. So the answer is indeed Streptococcus pneumoniae, most common cause of bacterial meningitis in adults. And you've got classical CSF findings of neutrophil predominance, low glucose, and high protein, which is consistent with bacterial meningitis. Now you've got a 30-year-old male patient with HIV or AIDS and a CD4 count of 50 cells per microliter. They're admitted with a 2-week history of progressive dyspnea, non-productive cough, and fever. His oxygen saturation is 85% on room air. Chest X-ray shows diffuse bilateral interstitial infiltrates. What do you think here would be the most appropriate initial treatment? Okay. Any other takers? Only one? Okay. So the answer here would be trimethoprim sulfamethoxazole or cotrimoxazole. This patient's presentation is suggestive of pneumocystis xerovecii pneumonia or PCP, which is a common opportunistic infection in those patients who have got advanced HIV. That is the treatment of choice for PCP. 72-year-old man, history of severe diarrhea, fever, and abdominal pain. After being treated with clindamycin for a dental abscess, you do a stool test, which confirms the presence of C. diff toxin or Clostridium difficile toxin. So what is the best initial treatment? Okay. B, A, B. Okay. So answer would be vancomycin, basically, and that too oral vancomycin. You've got two options such as IV vancomycin and oral vancomycin. It will still be oral vancomycin. First line treatment for severe C. diff infection, specifically in cases of severe diarrhea and systemic symptoms. Metronidazole is definitely a well-defined alternative, but less effective in severe cases. Sometimes, if the patients are not able to take orally, then these patients are also given, to the rectal route as a retention enema of vancomycin. A 60-year-old man admitted with sepsis due to a urinary tract infection. He's got a history of aortic valve replacement. Now, blood cultures are positive for Enterococcus faecalis. Which of these is most appropriate for treating this patient's infection? There's no ampicillin. Any other options? Ampicillin. The line is solid. Okay. So answer is ampicillin. It is the antibiotic of choice for treating Enterococcus faecalis infections, especially when the strain is susceptible. When the organism is not resistant, it is effective and is actually preferred over using vancomycin. Okay. So now you've got a 40-year-old woman, no significant past medical history, presents with a 5-day history of fever, arthralgia, and a rash. Now, she has recently returned from a trip to Brazil. Examination reveals a diffuse maculopapular rash and conjunctivitis. Which of this is the most likely diagnosis? Okay. Supriya has been the one to answer. Then Rashman Rajan, John Chuku. Okay. Right. So I guess people have got it now. Answer is indeed Zika virus infection. So whenever you get fever, rash, arthralgia, as well as conjunctivitis, along with recent travel to an area with Zika virus circulation, it is highly suggestive of the Zika virus infection. You can get similar presentations of dengue and chikungunya, but conjunctivitis would be more seen or more common to attributable to a Zika virus infection. Okay. Here, you've got a 55-year-old male who presents to you with fever, chills, and a new onset murmur. He's got a history of mitral valve prolapse, and blood cultures are positive for Staph aureus. Now, which of the following complications is most likely if the infection is not adequately treated? Okay, everybody seems to be having a consensus on this. Any other answers? Okay. So here the answer is indeed heart failure. The explanation being that it can lead to infective endocarditis, particularly on a previously abnormal valve, which can lead to valvular insufficiency or regurgitant lesion, and subsequently a heart failure if not promptly and adequately treated. Now you've got a 25-year-old man who presents with a 3-day history of fever, sore throat, and swollen lymph nodes. This guy reports recent unprotected sexual contact with multiple partners. Examination reveals oral ulcers and a generalized maculopapular rash. Which test do you think would be the most appropriate to confirm the diagnosis? Can I have the answers? Mhm. B, D, D. Okay. So wait a minute. So the answer would be, wait a minute. So the answer would be HIV antibody and antigen test. The option is C. The patient's symptoms and history of recent high-risk sexual behavior will suggest acute HIV infection. Hence, the combination of antibody and antigen test
ఏ అద్నాన్ కాల్
is appropriate for
కాల్ ఇంత
diagnosing
ముందు
early
వచ్చింది
HIV infection. Can I
కాల్ ఇంత
ask
మూంజిలో
everybody
వచ్చింది
to switch off their mics?
మూంజిలో కాల్ వచ్చలమ్మా
Next would be a 48-year-old male. History of cirrhosis, presents to you with fever, abdominal pain, and confusion. On examination, he has got ascites and tenderness in the right upper quadrant. You do a diagnostic tap or a paracentesis, which tells you that there's a high white cell count with a predominance of neutrophils. What do you think is the most likely diagnosis? Now, this is easy one. Supriya got it right. Okay, right. It is indeed spontaneous bacterial peritonitis. You get a presence of fever, abdominal pain, confusion, and an ascitic fluid tap with a high white cell count with a neutrophilic predominance that indicates spontaneous bacterial peritonitis, which is a very common complication of cirrhosis. Now, a 35-year-old man who presents with fever, headache, and a stiff neck. He also complains. Can I ask other people to switch off their mics, please? So, a 35-year-old man presents with fever, headache, and a stiff neck. He also complains of sensitivity to light and nausea. You do a lumbar puncture, which gives you slightly elevated protein level, normal glucose, and the predominance of lymphocytes. What do you think is the likely causative agent here? C is what everybody is telling me. It is indeed herpes simplex virus. You get findings of slightly elevated protein, normal glucose, and lymphocytic predominance, which are suggestive of viral meningitis, with herpes simplex virus being a common cause of such a presentation. Now, I got next question. 68-year-old male with COPD admitted to ICU with severe community-acquired pneumonia. He started on appropriate antibiotic therapy, but his condition deteriorates with increasing respiratory distress and a need for mechanical ventilation. What is the most appropriate next step in managing this patient? Can I get the answers? Addition of corticosteroids. That's what Hiren has said. Aditya. Intensive physiotherapy is what Lakshmana says. Okay. So the answer for this would be addition of corticosteroids. See, in cases of severe pneumonia who require mechanical ventilation, addition of steroids may actually help reduce the inflammation and improve the outcomes by reducing the risk of progression to acute respiratory distress syndrome. Somebody else's mic is also on, please. John, is your mic on? Okay. So next question. 50-year-old male, recently diagnosed diabetic, presents with a fever and a painful swelling in the groin area. You do an examination. This guy has got an erythema and swelling over his right thigh and a fluctuant mass in the right inguinal area. What do you think is the most appropriate management here? Both the options have been given. Any other choices? Okay. All of you are going for IND. So answer is indeed incision and drainage. Patient's presentation is suggestive of an abscess, which requires incision and drainage, or IND, which a lot of people call it as. Antibiotic therapy may be necessary as adjunctive therapy, but the primary treatment for an abscess is drainage, or basically a source control. Now you've got a 70-year-old man, history of ischemic heart disease, who presents to the ICU with a fever and altered mental status. He recently underwent cardiac surgery, blood cultures grew MRSA. Which antibiotic do you think is the best choice for treating this infection? You've got four options. Okay, so everybody is quoting vancomycin. Answer is that only. It is basically the first line treatment for MRSA infections, particularly in a hospital setting and following surgery. Linezolid and daptomycin remain alternative medications, more so where you get vancomycin resistance or intolerance. Now you've got a 32-year-old woman who presents with high fever, chills, and severe pain in her right leg. She's got a history of IV drug use. On examination, the right leg is swollen, red, and tender with bulla formation. What do you think is the most likely diagnosis here? Okay. So there's a toss up between A and C. Huh? So the answer is C. Basically, blistering or bulla formation is more common with necrotizing fasciitis. Having said that, combination of pain, swelling, redness, and bulla formation in a patient with who has got a history of IV drug abuse, highly suggestive of necrotizing fasciitis, rapidly progressive infection, which requires a urgent surgical intervention. Now we are finished with the infectious disease part of it. And next, what we are going to do would be the AKI part of it or the acute kidney injury part of it. So definition of AKI does not include what? Increase in serum creatinine by more than 0.3 milligram per deciliter within 48 hours. Increase in serum creatinine to more than 1.5 times baseline, which is known or presumed to have occurred within the prior 7 days. Urine volume of less than 0.5 mils per kg per hour for 6 hours, and increase in serum creatinine by more than 0.3 milligram per deciliter within 72 hours. Answers? Okay. B and D. Okay. Correct answer is D here. Increase in serum creatinine by more than 0.3 milligram per deciliter within 72 hours. All the other statements are correct in the sense that increase in serum creatinine more than 0.3 within 48 hours, increase in serum creatinine to more than 1.5 times baseline within the prior 7 days, and urine volume of less than 0.5 milligram per kg per hour for 6 hours. All of them go into the criteria. Now, when it comes to dose of effluent volume of CRRT in patients of AKI in critically ill, what do you think is the dose that we would want to use? It's a simple question. We're talking about CRRT, huh? Remember that. Okay. We've got divided opinions, A and B. So answer is A here. 20 to 25 mils per kg per hour is what is decided to be the correct answer. Some of us can argue that maybe there's some amount of wastage which happens in CRRT. So conceptually, should we write 25 to 30 mils per kg per hour? But that not being the case, the correct answer here would be as prescribed, would be 20 to 25 mils per kg per hour, assuming there are no interruptions, assuming there is no other variable which can, sort of lead to interruptions or any, change in the flow rates of CRR. Okay, so femoral catheter has to be inserted how much? At least. Okay, there are a lot of C's. Huh? The answer is correct. It is C. Were it to be a jugular catheter, then the correct answer would have been somewhere between 13 to 14 centimeter. And that is what we are going to talk about, right? Uh, why do you need an adequate length of femoral catheter? Why do you need to insert it in order to avoid what? You want to avoid catheter block, you want to avoid recirculation, you want to avoid DVT or a catheter-related infection, whatever. Can we have the answers here? Okay. So the correct answer would be actually to avoid recirculation, right? What is the anticoagulation of choice of CRRT? whether it is citrate, whether it is heparin, whether it is low molecular weight heparin, or whether there is no anticoagulation at all. So correct answer is indeed A. That is what it is, citrate anticoagulation. The only drawback or probably the things that I see in its adoption for use would be the cost factor. But other than that, it is indeed the choice of anticoagulation as far as CRRT is concerned. So replacement fluids should be having the following buffer: bicarbonate, acetate, lactate, or none of the above. Can I have the answer here? Okay, all of a bicarbonate. Huh? That is correct answer. When we look at it, among the replacement fluids, bicarbonate is one of the most essential buffers, and it should be there mandatory. Now, bradykinin release syndrome is more pronounced in patients on AC inhibitors, beta blockers, calcium channel blockers, and diuretics. Which one of them? Simple, actually. Well, C. John thinks of it as C. Let's see. Correct answer is indeed A. And AC inhibitors are the ones which are reported most commonly to cause a bradykinin release syndrome. To prevent a bradykinin release syndrome, what are the filters now coated with? Whether it is heparin, whether it is polyethylene amine, or surfactant, or whether it is none of the above. Okay. So the correct answer is indeed polyethylene. That is the right answer here. Now, which of the following markers is used to have both diagnostic and prognostic value in acute kidney injury? Now, remember this, both diagnostic as well as prognostic value. That becomes important. Okay. Right. So the answer is indeed NGAR. That can have both diagnostic as well as prognostic value in acute kidney injury. Cystatin C may be a more of use maybe in contrast-induced injury, but other than that, NGAL is the marker that you should be looking out for. The following values indicate pre-renal acute renal failure in the presence of diuretics. The options are fractional excretion of sodium less than 1%, fractional excretion of urea less than 35%, fractional excretion of uric acid more than 8%, and fractional excretion of sodium more than 5%. I've got all answers maybe. Only B, somebody has not answered B yet. The rest everything has been answered. So what would be your correct option here? That is what it is. The fractional excretion of urea less than 35%. All of the others were answered to a varying degree. It is B, that is the correct answer. That is fractional excretion of urea of less than 35%. Now, a patient of cirrhosis comes to us with altered sensorium. Urinary parameters are as follows: FeNA of less than 1%, fractional excretion of urea of less than 25%, creatinine urea protein ratio of more than 40:1, and resistivity index which is less than 0.76. So, what do you think is happening here? What is the patient suffering from? A volume responsive prerenal ARF, a volume unresponsive acute kidney injury, hepatorenal syndrome, or a postrenal acute renal failure? So answers are divided between A and C. And your correct answer is A indeed. It is a volume responsive pre-renal acute renal failure. That is what the parameters indicate here. Because of cirrhosis, I think many people thought that it is a hepatorenal syndrome, but the question is not as straightforward. The pathophysiology of hepatorenal syndrome includes A. Sodium retention following stimulation of renin-angiotensin aldosterone system, water retention due to stimulation of arginine vasopressin, and renal vasoconstriction following stimulation of sympathetic nervous system. And of course, D option is all of the above. So what do you think is happening here? Hmm. C, A. So the answer here would be C. That is renal vasoconstriction following stimulation of sympathetic nervous system. That is your correct answer. Contrast-induced acute kidney injury will be treated as follows. With what? Intermittent hemodialysis, continuous veno-venous dialysis with hemofiltration, oral N-acetylcysteine, and of course crystalloids. So what do you think is your correct answer here? Okay, they got it right. So the answer is indeed crystalloids. That would be your correct answer. Now, the most important factor in preventing clotting of the dialysis filter is what? Anticoagulants, filtration fraction, ratio of pre and post dilution replacement fluid, or a proper catheter placement. Can I have the answers? B, C, D, B, C. Okay. So the answer here would be D. That is proper catheter placement. You know, that is the most important factor in preventing clotting of the dialysis filter. Regarding serum level monitoring of aminoglycosides, the following statement is true. It has to be monitored every 48 hours in a single daily dosing. First option. B should be monitored every 48 hours in multiple daily dosing. C does not need monitoring. D should be monitored every 72 hours in a single daily dose. Can I have the answers? Everybody seems to have got it. It is indeed to be monitored every 48 hours in a single daily dose. Okay, this is another question. While evaluating a 23-year-old female patient who presents to the emergency department after a marathon, it was found that she is lethargic and hypotensive. Labs tell you that serum sodium is 138, potassium is 5.3, chloride is 109, and TCO2 is 12 with a normal value of 18 to 25, urea 23, creatinine of 382 with a normal value of 6200, serum osmolarity 325, urine sodium 66 millimoles per liter, urine creatinine 4 millimoles per liter, and a urine osmolarity of 275 milliosmoles per kg. Now, what do you think is the most likely diagnosis and what is happening here? DD, D, C. Oh, again, all options have been worked on. So the correct answer for this would be answer C, that is acute tubular necrosis. This is what it indicates. Okay. This is what has happened here. Now, what is incorrect regarding acute renal failure? A. In pre-renal failure, the ratio of urea is to creatinine is increased above the normal. Second option is B. Most common cause of renal ARF is acute tubular interstitial nephritis. C is urine analysis with microscopic hematuria, pyuria, and presence of granular, epithelial, and RBC casts is consistent with acute glomerulonephritis. And D, of course, in renal acute renal failure, the urine sodium is more than 10 millimoles per liter and osmolarity is less than 350. Right? What do you think is correct here?
C. C is correct.
Okay. Anybody with any other options? Everybody's coming around the same. Okay. So answer here is B. You know, it is the opposite, you know. Basically, the most common, I mean, you need to go around and do your renal function test tables again. You will get the answers to all of this. And the most common cause of renal in this particular set of options, the most correct or the appropriate option, remember that most correct and appropriate option would be the most common cause of acute renal failure is acute tubular interstitial nephritis.
Okay, is that the same thing as acute tubular necrosis, ATN?
Yes, John, tell me.
Yeah, okay, because I know it's ATN. So, but when I saw tubular interstitial nephritis, that's why I didn't tick it. But I know it's ATN that is the commonest. You know.
Correct, correct. But see, that's where the catch of the question is.
Okay.
Okay. So next one would be regarding fractional excretion of uric acid. The following statement is true. Fractional excretion of uric acid more than 10% indicates pre-renal causes. Fractional excretion of uric acid less than 10% indicates SIADH. Fractional excretion of uric acid less than 10% indicates pre-renal ARF. And fractional excretion of uric acid has no significance at all. Okay, one answer A, B. 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 Okay. So the correct answer here would be C, fractional excretion of uric acid of less than 10%, It indicates pre-renal acute renal failure. And this should be simpler one. I know the previous ones have been difficult in terms of, going to the nitty-gritties of physiology. The ideal filtration fraction to help in circuit survival while performing CVVHDF should be kept below 15%, 25%, 30%, or 32%. 25%, 15%. Okay. So the correct answer here would be, remember, 25% or B, that is supposed to be the ideal filtration fraction. That would keep your, circuit intact while you are doing your CVVHTF. That's again a dictum, one of the thumb rules.
I thought it's 20%.
It is the most appropriate option among all of these.
Okay.
15% cannot be there, so then it comes to 25%.
That's okay.
How does bicarbonate therapy affect the calcium concentration when it is used for severe acidosis? A, total calcium concentration decreases. B, ionized calcium concentration decreases. C, ionized calcium concentration becomes unaffected. And D, ionized calcium concentration increases. This is again physiology. Okay. So the answer is indeed B. You have answered it correctly. Ionized calcium concentration will actually decrease once you give bicarbonate for severe acidosis. Thank you. Thank you. I'm not sure if somebody else is supposed to follow my time. Let me just check with Sana.
Yes, sir.
Okay, my session is over.
Okay, sir.
Okay. Thank you, everyone.
Thank you,
Thank
everyone.
you, sir. Thank you, sir. We are really grateful. Very enlightening.
Thank you. Thank you.